All right, here we are again. This is another slide deck that I wanted to quickly record and get out there and get up there. And this is basically on a patient-centered medical home. Um, and man, let me tell you, you should never sit down and do a presentation. It's absolutely horrible. I like to walk around, move around a little bit. But I'm going to go ahead and do it. I'm going to plow through it for you guys. So basically, this is I think we went to Spirit Lake, North Dakota, and these guys are doing well. They were an IPC site, had a very small microsystem. It hadn't evolved to the rest. They got involved in another project called the Quality Improvement Project that was looking at HIV and STD, and they wanted to to move it a little bit further, and they wanted to make some changes on it and get a little bit better. So, but they were kind of stuck in a lot of ways. So we kind of went there and we kind of looked at their system. And what we realized quite quickly is that they had a very small microsystem that was, kind of geared around improvement, but it hadn't really spread yet to the rest of the facility or the rest of the clinic. But there was some will there. And so what we went out there and we did is we kind of wanted to build a little bit of will. So this is kind of how we started out the presentation. These are some of the things that we went over, and I actually think they'll be very helpful for everyone else. So this first one was the concept that you could pretty much ask anybody that change is inevitable, right? And you can ask people how they want to change, and they most always say they want to change for the better. Nobody really thinks by the end of this month, I really hope to be homeless and living on the street, or I really hope to wreck this, or it's not our human nature. We actually want to get better or build or master something. And so I saw this. My wife's a school teacher, and I saw this in her room, and I thought, this is genius. I'm going to have to take this and put it into one of our presentations that we give. And that's exactly what I did. And you guys probably seen this before, but the fundamental question is, are you happy? So think about your system. Are you happy? No. Do you want to be happy? Yes. Change something. Very simple, right? If you don't want to be happy, keep doing whatever you're doing. If you are happy, yes, keep doing whatever you're doing. So this is a really a good thing. But how do we do that? Let's say we want to be happy. We choose to change. Well, you got to give people some kind of model to do that. You got to give them some kind of toolkit, if you will, a grab bag of change elements that they can go deploy at their system. And with that, we really looked at the patient-centered medical home models and IPC in particular with IHS. So IPC was improving patient care. It is improving patient care. And so that was the model that we had to offer, and I'm going to go into that a little bit, and how at your clinic, how these pieces of the puzzle are already there. Sometimes we don't put them together correctly, but if we put them together correctly, we'll change it fundamentally. So, what is a patient-centered medical home? Well, first of all, we can talk about what it is not. And if we look at this very unique point in time, and especially the debate, you guys hear the debate that's going on. Half of the stuff that everybody's saying at the national level is malarkey. The other half is probably spot on correct. We'll learn this as we move forward. But basically the idea is, back in the day when you had your home doctor or your family doctor, they would come to your house with a suitcase, and they knew everything about you. They knew everything about your family, and they saw everybody in your family. That was your family doctor. That worked. Somewhere along the way, we got away from that. We became these big, giant corporations and collaboratives and all this other stuff. And if you think about how you feel as you move through these systems, think about that. You guys are everything that we have unique, or everything that makes us unique also makes us the same in a lot of ways. We are all patients. So not only are we healthcare, but we all know what it's like to be a patient, right? So when we go through these systems, think about how it feels. A lot of times you'll feel like cattle, especially if you're in a very big hospital. So it's really hard to get to that sense of relationship and intimacy with your care providers. What we saw and what we see happening in the medical industry is that, flat out, it's pay for procedure kind of based. And in this system, what we have is insurance companies who are growing stronger in a lot of ways. You have pharmaceutical companies that are probably growing stronger in this process. You have hospitals that are kind of like, corporations in a lot of ways that are growing bigger and stronger. And we see a tremendous amount of weight on the staff and the provider themselves. So the provider is like, and every provider out there can listen to me on this and probably agree with me on this, is that it's, what's the pressure? Where is it coming from? See more patients, do more stuff. See more patients, do more stuff. And we're losing focus of, hey, I'm here to see this patient, but ask them about their history and ask them about, and it's just see more faster. And so it's kind of gotten bad. We've got to shake that tree up. And that's exactly what's happening. And who knows, 10 years down the road, it might be all bad. But what it's really equivalating to is, let's start to design around the patient themselves, just like all the other industries have done and have been very successful at. Apple says, hey, let's design around the customer. Hello. And they're, $400 billion richer because of it. So what healthcare is starting to do is wake up a little bit, to what other industries have done. And they're starting to say, we need to really rethink things here. We need to really design our systems around the patient, because in reality, we're sicker than ever, and it's kind of broken. And right now, we're looking at healthcare in a very triage manner, or not a triage, but more so like it's an urgent care clinic, or more so like it's an ER, where we're the Band-Aid at the end. And what we want to do is get back on that front line, back on really not just managing a patient list, but helping to manage a family and to understand the area or the community that we live in and care. So, wow, that was a lot. That's a patient-centered medical home. So we're going to move forward a little bit here, and kind of we'll go here to the godfather of patient-centered medical home is William Osler. It is much more important to know what sort of patient has a disease than what sort of disease a patient has. And you probably, there's another one that he says, a good physician treats the disease, a great physician treats the patient who has the disease, something very similar. But what is that really? That's developing a relationship, knowing your patients and then knowing you. So on this next slide, you feel free to go ahead and see what jumps out at you on this. So we look at this slide right here, and there's something that's in a different color. Obviously, it's meant to be in a different color. It's an effective relationships. So we look at the whole entire thing as like an ecosystem. You have the whole entire community, all of you working together for common goals. You have the healthcare organization who is looking at what they can do. Self-management support, their delivery system, how they provide that care, their decision support, how they make the decisions, their clinical information systems. These are all leverage points. How they want to deliver that is safe, efficient, patient-centered, effective, and timely. And then hopefully, if we do this correctly, we live in a time more than ever that patients know stuff, right? They have the internet, they have all sorts of stuff. But they're also starting to get access to their medical records, which, by golly, they should have the access to their medical records. It's their medical records. And that's where we see a lot of this push, is like, why the healthcare, why do they feel like they got to own these medical records? It's the patient's medical record. And what we're seeing, just like whether it's your bank account, you don't call up your bank account and say, hey, how much money do I have? And they're like, yeah, I can't tell you that right now. No, we can log in and change stuff around. So now what we're getting is activated family and community and an informed activated patient. This is great. We live in the time of what I like to call the inpatient patient. They're starting to know stuff, and they're coming to us, the providers, and us, the care systems, as like, hey, what is this? What is that? Guess what? This is beautiful. This is like proactive. We're starting to get on the front edge. We say for years that we want, it's the patient that needs to be involved, and the patient needs to do this. Well, they are, and when they are involved and they are ready and they are activated, are we ready, and are we informed, and are we there to provide that care? So are we prepared? Are we proactive? And are we partnering with the communities? Are we a prepared, proactive care team? That's the question. If we do this correctly, we develop that relationship, and we have an improved health outcome. So this is kind of what it looks like. And I'll go a little bit into this slide, and I'll also go a little bit into what I think we fail to do this, is basically what I'm saying. What we do is, what you'll see at sites in different places and different clinics is they'll go grab the technology bit, and they think it's a silver bullet that's going to solve all their problems. But these things, remember, we're fundamentally changing the system. You have to do all of them in a parallel manner for this to work, and you have to have this be designed around the patient. So, hey, yeah, congratulations, we built a new hospital. Congratulations, we just deployed the electronic health record, but yet they're seeing problems because they're not doing any of the other things. We've seen a lot of sites go to a patient-centered medical home or an IPC on paper, yeah, and they say, hey, we're doing that. No, you're not doing that. You really have to dig in, all right? So let's take a look at this. You have technology, so this is a great leveraging point. It's a tool, though, to help you meet the ends of what you're trying to do. So you have a technology that can help you with things like clinical measures, can help you, measure these things, quality measures. You develop your case management team. You get your care teams that have case managers on them. You get a primary care provider, and most importantly, you got to make sure that people are able to access your system. It's a moot point if they can't get in to see the provider, right? So what is the concept behind a primary care provider? Well, you are not going to know 30,000 people. You are not going to know really 6,000 people. What we're going to try and do is, how do you eat an elephant? One bite at a time. So we're going to say, we want you to develop a relationship, so what we're going to give you is 1,000 people. This is a little bit easier to do, right? I have a panel. I've been panel patients. I have a panel of 1,000 people to 600 people. Well, I can start to manage that problem list. I can start to, I get a care team along with that? Awesome. So I have a behavioral health person that I can talk to. I have a dentist that I can work with. I have a case manager that's going to help me. So when I refer a patient out, they're going to help manage that process and make sure that patient doesn't fall through the cracks. I actually have the technology to do that and to get the quality measures to see if it's getting done and to order the referrals and to check on that and to see this information coming back into us. We have the patients coming into our system with access, and all this is the new design. It's designing around a patient-centered medical home, or IPC, improving patient care. And this is beautiful. This is what it's not, and this is a bit of an impact story, but this is my father who passed away May 15th, and this is him the day after he was diagnosed with stage 4 colon cancer. And he was in the private sector, getting the best that healthcare had to offer, supposedly. And he's being funny here. Oh, look at the book I happen to be reading. Kind of like a bucket list book, 1,000 places to see before you die. But I'll tell you what his system did not have is they did not have care teams. They did not have quality measures. They were not impaneling patients and creating that accountability to the providers with primary care providers and making those things manageable. Instead, it was, you got to see everybody and see more and more. They didn't have case management. So in reality, what happened is he slipped through the cracks. He came in with large pull-ups. 3 years went by. There was no measures saying these are all the patients that are due. This is a percentage of the population that's been screened. There was no provider who actually had that panel, was managing that health with his care team and with his case manager. So it turned out 4 or 5 years go by, and next thing you know, it's spread. So what we want to do is avoid this in our own healthcare systems. We want to stop that from happening. The good news is all these tools already exist. You could just reconfigure your team and reconfigure the way you guys deliver care tomorrow. You could start this process. So the first thing, let's say you decided that you want to start doing it. I think the first thing you need to do is take a look at where you're at and how are we going to design our system and change our system. So sometimes when you run the numbers and you really start to dig in and take a hold of this stuff, it's not a good sight, right? And you start to realize we are not doing too great. We're trying to be at minimum very low standard of colorectal screening of a population, 41%. We're at 37%. We could do better. We can get these numbers up in the days. So the first thing is to just take a look at where you're at and where do you want to go. Not good, right? The next thing is keep these quality measures coming. Start looking at stuff. Start building it up. This is building knowledge. So now we start looking at month by month. The alcohol screening seems to be going down a little bit. The depression screening seems to be going down a little bit. What are we doing wrong? Let's take a look at these. Domestic violence seems to be holding steady. Tobacco use screening seems to be going down. This is where we make the tweaks and we start to design the system. And we start to really focus on, well, what is working about the DV screen, awkward, which isn't working with the other screens, and what can we do better? And it really takes, rolling up the sleeves and digging in and really starting to make an active push towards improving the care that we give. So I think a good place to start is, I always like to show this slide, and this is a great slide, and there's probably better ones out there. I have no idea why it's backwards. Bad design. It should go that way. Maybe I'll remake it tonight. But I think a good starting point is, just like it was at Spirit Lake, was to get everybody in the room together. They have this will. They have this passion. It's healthcare. That's why they're in the field that they do. But give them the tools to go forward with it. Get them all in the room. And say, we are going to become a patient-centered medical home. That's what we're going to do. And we're going to start having meetings once a week. And we're going to get everybody in the room, and we're going to start talking and picking topics and come up with agenda and kind of get this going. And we're just going to, one bite at a time, start moving in this direction. And I want everybody to know that when you start this process, it's going to be great. You got this forming. Yeah, we're going to do this. We're all going to get together. We're starting to become an IPC, or patient-centered medical home. The very next step is storming. What you're going to have is people challenging each other's. You're going to have little beliefs popping up. That's wrong. So-and-so is an idiot. We can never do that. You're going to have the different types of people, the analytical folks and the nurturing folks, and the red, I'm a hard charger, challenge-driven person, all battling it out. This is good. This is storming. You want that to actually happen, and I want everyone to know that this is completely healthy. It's part of the process, because what you start to do is make compromises with each other and what's important, the patient, and you start to norm. You start looking like, well, I can do this, and we can do that, and we can, oh yeah, I guess you're right. You had a good point. And then finally we start performing. We start getting better healthcare outcomes. So I hope this works for you guys. I hope you're able to take it back and really think, have we in the past thought about our system and really designing it this way? Have we done it all at the same time? Have we looked at it all, or have we kind of just said we're doing this and then it fell apart? No, I think it's a starting place, and everybody wants this in a healthcare facility. So I hope you enjoy. Have a good day.